Hi, Professor and classmates. My name is Samantha Kreitz, and I am going to do a case study presentation on a patient who was diagnosed with relapsing remitting multiple sclerosis. The date is December 10th, 2019. We'll start with the history and physical exam. This patient presented to the clinic with the complaint of a lost feeling from the navel down to his feet 2 weeks ago. He denied recent trauma or injury. The patient recently rode his motorcycle 500 miles and noticed the numbness after being in the jacuzzi for 1 hour. There was no history of similar occurrences in the past. History of present illness. This is a 34-year-old Anglo male. He presented to the clinic with complaints of sudden, complete loss of sensation. There was no tingling or pain from the navel down, with functioning remaining intact. There was no history of injury to the area, no falls since the loss of sensation occurred, no loss of bowel or bladder control. The patient continues to have regular bowel and bladder habits. Past medical history. The patient has had multiple accidental fractures. Immunizations are current. Surgeries. He's got bilateral bunion repair back in 1999 and a right shoulder repair also in 1999. No allergies and currently does not take any medications. Past family history. Mother had Debek's disease, which is neuromyelitis, and she died in 2005 from ovarian cancer. Patient's father is alive and healthy at 86 years old, and patient has 2 siblings, a 32-year-old brother who is healthy, and a 23-year-old sister who is obese. Personal social history. Education. Patient has a master's degree in hospital administration. Occupation, he is a CEO and a hospital administrator in a small town. Marital status, he is single. Alcohol, he is not a drinker, but he is a former drinker. Drug use, there is none. Smoking, he is a non-smoker, never was a smoker, and but he does chew tobacco. Exercise, he does exercise 3 times a week. And nutrition, he maintains an excellent diet, and his religion is Catholic. Review of systems. Generally speaking, he is a well-developed, normal weight male, alert, and he is contributory to exam. Hair, skin, and nails, he is negative for rash or dry skin. Head, negative for syncope, negative for tenderness upon palpation or maxillofacial sinuses. Neck, negative for neck stiffness or decreased range of motion, negative for cervical lymphadenopathy. Eyes, he's negative for eye pain, redness, irritation, or tearing. He denies concern about hearing. Go down to ears, negative for redness or drainage. And nose, he is negative for drainage. Mouth and throat, he is negative for sore throat or pain upon swallowing. Cardiovascular is negative for chest pain, orthopnea, or palpitations. Genital urinary, he is negative for genital urinary pain, rash, or itching. Negative for change in bladder habits. Respiratory, he's negative for cough. GI, he's negative for a change in bowel habits, negative for diarrhea, negative for nausea or vomiting, negative for loss of appetite, and negative for abdominal pain. Musculoskeletal, he's negative for musculoskeletal pain, change in range of motion, stiffness of joints, or swelling. Peripheral, is negative for cyanosis or swelling. Neurological, he is negative for syncope, seizures, weakness, or tremors. He is positive for numbness below his navel, positive for failure to detect pinprick at bilateral hip, thigh, knee, calf, heel, plantar and great toe bilaterally. Psychiatric, he is negative for mood instability. Moving on to the physical exam, his vital signs are a temp of 98.6, heart rate is 60, respiratory rate is 16, blood pressure is 130/60, and his weight is 208. His general appearance, he is a healthy appearing male and contributory to exam. HEENT, his head, scalp is non-tender, hair is evenly distributed, eyes, sclera is white, vision is intact. Ears, bilateral ears are free of redness, tympanic membranes are pearly gray. Nose, nasal turbinates are free of swelling or redness. Mouth and throat, oral mucosa is pink and moist, tonsils are 2+ with no exudates. Neck, trachea is midline with no gross deformity. Lymph nodes, there is no lymph adenopathy. His chest, blood signs are clear to auscultation bilaterally. There are no retractions and he is in no respiratory distress. He has no cough. Cardiac, his heart rate is regular, S1 and S2 is heard with no splitting. There are no murmurs, rubs, or clicks. His abdomen, bowel sounds are present times 4 quadrants. Abdomen is flat, non-tender to palpation. Genitourinary, bladder is non-distended. Skin is intact, warm and dry. No rashes are noted. Musculoskeletal, his joints have normal mobility. Neurologic, his cranial nerves 2 to 10 are grossly intact. Equal strength bilaterally, face is symmetrical, alert and oriented times 4. Lack of sensation is noted, tested with the patient's eyes closed. Patient is unable to detect touch bilaterally at any point below his navel. He failed his Babinski bilaterally. Psychiatric, his mood is stable. Okay, moving on to his differential diagnosis. The first diagnosis I suspect is multiple sclerosis. The presence of multiple demyelinating plaques are noted in MRI. The oligoclonal bands are present in his CSF, and the new onset of symptoms with no history of similar symptoms confirms the diagnosis of MS. The second differential diagnosis I considered was acute disseminated encephalomyelitis, or ADEM. This is an autoimmune demyelinating disease of the central nervous system. It usually follows a systemic viral infection or vaccination. There is perivascular inflammation, edema, and demyelination within the central nervous system, and patients with ADEM present with a rapid development of focal or multifocal neurologic dysfunction, including motor, sensory, cranial nerve, and brainstem deficits, as well as nonspecific symptoms such as headache, malaise, and altered mental status. It usually produces a widespread central nervous system disturbance, often with impaired consciousness and/or encephalopathy. However, MS typically is monosymptomatic, and our patient presents with only one symptom, numbness of his lower extremities. Therefore, ADEM is ruled out. And the third diagnosis was a differential diagnosis was MOG, IgG associated encephalomyelitis. Although there is substantial overlap in symptoms between MS and MOG, IgG associated encephalomyelitis, most MOG, IgG patients do not have CSF specific oligoclonal bands in their CSF, unlike those with MS. Additionally, the CSF findings in a patient with MOG IgG can include a neutrophilic pleocytosis, which is the process by which phagocytes ingest other cells, and or a white count above 50, both of which are rarely seen in MS. Our patient did in fact have oligoclonal bands in his CSF, and therefore MOG IgG is ruled out. Diagnostics. MRI of the brain and spinal cord with and without contrast. This is the gold standard with MS patients. The result was we found multiple demyelinating plaques noted in the juxtacortical regions, corpus callosum and pons, and cervical segment of the spinal cord. Also ordered a lumbar puncture, which resulted in finding of positive oligoclonal immunoglobulin G, or IgG bands. And a lumbar puncture is not a requirement for the diagnosis of MS, but it can help increase confidence for the diagnosis. When a patient presents with a clinically isolated syndrome, which makes providers suspect MS, the presence of oligoclonal bands in the CSF highly suggests MS. An oligoclonal band is a protein called an immunoglobulin, and their presence suggests inflammation of the central nervous system due to infection or another disease. If similar bands are not also present in the blood, then MS is highly suspected. There was also an evoked potentials test, and the result of that was negative for proof of MS. This test can detect problems with the spinal cord, which can cause numbness in the arms and legs. And for this test, electrodes are attached to the wrist, back of knee, and other locations, and applies a mild electrical stimulus through the electrodes. Electrodes on the scalp then measure the amount of time it takes for the current to travel along nerves to the brain. Also ordered an electromyogram, and the result was negative for proof of MS. And an electromyogram measures the electrical activity on the nerves and the muscles. It consists of two parts: a nerve conduction study, which measures the ability of nerves to transmit electrical impulses to the respective muscles. And the second part is a needle electrode examination, which measures the electrical activity within the muscles. So the treatment plan. So firstly, I want to mention that there are three forms of MS. First off, there is relapsing remitting MS, and this is where the patient has flare-ups of the disease, much like our patient presented with numbness below the navel. There's also secondary progressive MS, and this is the stage that comes after relapsing remitting, and this is where the disability gets steadily worse. With each relapse of MS, there is some recovery, but not complete recovery, and each recovery gets slightly worse. Then studies show that patients typically go from, there's a completely different kind of MS called primary progressive MS, and this is where a patient has steadily worsening neurologic function in the very beginning at diagnosis without distinct relapses. And but this treatment plan, for the purposes of this PowerPoint presentation, will address the relapsing remitting multiple sclerosis in adults. Okay, so there is no cure for any form of MS. However, a person with relapsing remitting MS is placed on an immunomodulator agent. This could be IV, IM, or PO, to decrease the relapse rate and slow the accumulation of brain or spinal cord lesions. Additionally, when a patient comes in to the provider with a suspected relapse, an MRI of the brain or spinal cord should be ordered, which would typically show a new lesion. And this is the body's immune system being attacked in the myelin sheath covering the nerve, causing an interruption in signal transmission from the brain. So a flare-up of the disease, which is defined as a neurological disturbance lasting longer than 24 hours with a preceding period of clinical stability of at least 30 days without an explanation of infection or fever. So a flare-up requires a regimen of glucocorticoids to calm the inflammation down. Mild sensory attacks are not treated medically, but treated symptomatically. In addition to a scheduled immunomodulator agent, and a PRN glucocorticoid treatment, the MS patient also needs a multidisciplinary team to manage the common complications and symptoms of MS, such as bladder and bowel dysfunction, cognitive impairment, heat intolerance, pain, sexual dysfunction, sleep disorders, spasticity, speech and swallowing dysfunction, tremor, vertigo, visual disturbances, and there's other symptoms as well. But not every patient experiences all of these problems at one time, but most every MS patient does face each of these challenges at one point or another. Application of advanced pharmacology. When a new lesion is identified on MRI, a 3 to 7 day course of IV methylprednisolone, 500 to 1,000 milligrams daily, with or without a prednisone taper, is usually used. As an alternative, the provider could give a 3 to 7 day course of oral prednisone, 625 milligrams to 1,250 milligrams daily, with or without a taper. Oral dosing requires many tablets, up to 20 tablets daily, but some patients still prefer this over IV treatment, since IV treatment requires sitting still for several hours for the infusion. And when deciding whether to treat the relapse by oral, IV, or IM route, some clinicians prefer to use the IV glucocorticoids because of evidence from one trial that oral glucocorticoid treatment is associated with an increased risk of recurrent optic neuritis. And this is especially so with a patient whose initial presenting symptom is related to vision changes. Our patient's initial presenting symptoms was numbness of the lower extremities, so the provider chose to treat him with oral glucocorticoids. And back to the previous slide, as far as an immunomodulator is concerned, the clinician placed the patient on teriflunomide, 7 to 14 milligrams. Let's see, going back to the previous slide. Okay, teriflunomide, 7 to 14 milligrams PLQ day, and teriflunomide's exact mechanism of action in MS is unknown, but it does inhibit pyrimidine synthesis via dihydroorotate dehydrogenase inhibition, which results in immunomodulatory and anti-inflammatory effects. It might also reduce the number of activated lymphocytes in the CNS. As far as labs to consider when on this medication, before administering the first dose, a baseline TB test must be given, and a baseline blood pressure must be checked, and then periodically. Periodic monitoring includes ALT every month for 6 months, and after 6 months of starting this medication, labs must be checked, including a CBC, LFT, and bilirubin. And this because this medication has high risk of hepatotoxicity. Okay, review of evidence-based practice. It's been known for some time, at least in my research, it seems like 10 to 15 years, that B cells has some factor in these MS flare-ups, but there hadn't been a whole lot of research on what factor B cells had to do with MS flare-ups until somewhat recently, in the last 5 to 10 years. So now we know that B cells may be a key to treating MS. There's increasing evidence that B cells contribute to the regulation of autoimmunity, as well as the pathogenesis of immune-mediated diseases, including MS. And there are several ways in which B cells are suspected to do this, because they produce antibodies, present antigens, stimulate and activate T cells, They drive anti-proliferation of brain-homing autoreactive CD4 plus T cells. They produce pro-inflammatory cytokines, and they form ectopic meningeal germinal centers, which are microstructures that form in lymphoid tissues. So the role of B cells in MS has been mostly ignored, even though it has been known that CSF taken from MS patients reveals the presence of these oligoclonal bands, which indicate production of immunoglobulins by oligoclonal B cells in the CNS, as well as the presence of B cells found in MS lesions. But recent research is starting to show, however, that B cells can have several phenotypes according to their cytokine profile and can be either pro-inflammatory or anti-inflammatory. They have also been found to be able to travel in and out of the CNS via the lymphatic vessels that line the dural sinuses, and can thus be carried into the cervical lymph nodes and make their way back into the CNS via the thoracic duct, systemic circulation, and the various brain barriers, and trigger a bout of CNS-triggered inflammation. Therefore, B cells can contribute to MS by antibody production, which is associated with demyelination, antigen presentation, which is associated with the secretion of inflammatory factors, activation of T cells, which in MS are sometimes dysfunctional, cytokine production, which results in tissue damage and inflammation in the CNS, and formation of ectopic germinal centers, which produce antibody-secreting plasma cells and memory B cells. So, how does this translate into evidence-based practice? How this translates into practice is that this information about B cells. This offers a potentially new treatment option for MS patients. What we can do is, if we can deplete these B cells that cause these flare-ups, then we can potentially reduce the flare-ups. So it's called B cell depletion therapy. B cell depletion therapy is highly effective against relapsing remitting MS. And evolving experience has shown that this therapy, combined with a sophisticated understanding of humoral immunity, has led to major progress in deciphering the immune pathogenesis of MS. Anti-CD20 MABS is referred to as B-cell depletion therapy, and it rapidly and profoundly depletes circulating CD20 plus B cells and remains depleted for 6 to 9 months. The therapy consists of an IV infusion of a medication. I'll probably mispronounce it, but the medication is called ublituximab. It's in parentheses, it's TGX-1101. It's a glyco-engineered anti-CD20 monoclonal antibody, and it's currently in phase 3 trials, but it's showing great promise. The goal is to eradicate relapses. So, an application of nursing theory into practice. The nursing theory that applies to MS is Dorothea Elizabeth Orum's self-care deficit nursing theory, also known as the Orum model of nursing. This theory defined nursing as the act of assisting others in the provision and management of self-care to maintain or improve human functioning at home level of effectiveness. People who have relapsing remitting MS live fairly normal, productive lives, but are randomly interrupted by a sudden debilitating CNS symptom. It could be blindness, imbalance, bladder dysfunction, or even a sudden addiction, such as pornography. It all depends on where the new lesion is located. And this disruption in their daily routine can jeopardize a job, relationships, or their health, even though it's temporary. So the self-care deficit theory seeks to help the patient through this temporary setback, both physically but also psychologically, so that when the symptoms are resolved, the patient can return to their daily life with as little disturbance as possible. Application of role development. The role of the nurse practitioner is to help the client understand their disease process and, as part of the multidisciplinary team, connect the members of the team to work together so that every aspect of the MS client's health as it is affected by the disease is taken care of. The U.S. Department of Veterans Affairs has employed a model of care for the MS patient called the Multiple Sclerosis Centers of Excellence, which functions much like a medical home model for the patient. It essentially is a hub and spoke network where their local VA serves as the hub, and the spokes are each of the specialties that the patient requires, as mentioned earlier in the presentation. This is the ideal type of program which would reach all the aspects of the patient's welfare, and the nurse practitioner can be an essential part of this system, coming alongside the patient and coordinating the services that the patient needs, much like an RN coordinates dietary, radiology, physical therapy, etc. for their patient that they're taking care of in the hospital. Parting thoughts. There have been major breakthroughs in MS research during the past 20 years due to new knowledge about the immune system and the use of MRI to monitor MS in patients. And consequently, new therapies have been found to reduce relapses in people who have relapsing, remitting MS. However, there's still plenty of work to be done. The nurse practitioner can be a part of that work, furthering the research, applying it to the patient, and educating him on what is available, and giving him hope that in the future, even better treatments are sure to come. Thank you. And these are my references.